Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington, and together we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a variety of brain and mental health conditions from the people with lived experience and their carers. In this episode, we'll be exploring dementia and what this disease could look like for the next generation. Globally, someone is diagnosed with dementia every 3 seconds, and it's a scary prospect for many of us as we age. But with new blood tests for diagnosing dementia and promising medications on the horizon, does the future look brighter for this disease? Joining our conversation is Associate Professor Nawaf Yassi, a neurologist at the Royal Melbourne Hospital, Joint Lab Head at WEHI, and Dementia Biomarker Researcher at the Florey. In addition, Annemarie Logan, whose husband was diagnosed at the age of 61, and Dr. Rebecca Nisbet, Head of the Antibody Therapeutics Group at the Florey Institute. Annemarie, I'm going to start with you, if that's okay.
Yeah, certainly is.
Tell us a little bit about your husband and yourself and your family. You have 2 kids.
Yeah, 2 adult children. My son will be turning 30 shortly. My daughter's 34. 2 dogs in the house as well. It was a population of 3, but we lost one. John was a property valuer and, great with stats and figures and data, and he used to annoy the kids profusely when he'd say, "Okay, that's plan A. What about plan B?" So they'd come up with a plan B and then he'd go, "And plan C?" Dot your I's, cross your T's kind of guy. Yeah.
Annemarie, tell us about the careers that you and your husband John had. Like, where were you in your careers before all this started?
John was a senior valuer at the state government. I worked in HR for a global company. And, everything was fine. Should have been rolling along, still rolling along now, but, everything changed when John started to, exhibit symptoms of not just forgetfulness, but mucking figures up.
So if we go back a bit there, like, what was the first thing? I know this is hard because we all start to forget things as we I forget things all the time. What were the first things you started to notice that weren't that standard stuff that we all accept with age but seemed to jump out as maybe a bit different?
For him, really dropping the ball with he was the one that, organised all the insurances and the bills, and he was mucking things up. He understood superannuation much better than I did, but, he was coming out with things like, "Oh, I didn't know that." And I thought, well, no, you were the one that told me that. A funny recount, I was in a shop, phone rang, phone call, the power's out. Oh, the power's out. But I can hear the TV in the background. And I said, well, it must be just a certain circuit. But there's no lights, it's dark. Turn the lamp on. Okay. I hang up. The guy standing next to me goes, kids. And I thought, no, that was my husband.
Right, interesting. Yeah, I was going to ask you, like, what other people noticed. So, I mean, when you're with someone all day, every day, you pick up on behavioural changes, but friends, extended family, what were people noticing?
That he was less talkative. John was the sort of person that was always right. He became more obstinate about that and forgetful of, he's one of 7 family functions. Someone would ring him and say, look, we're, having a barbecue on the weekend. He'd forget to tell me.
Right.
And they were noticing that. So they started, texting me or phoning me, and they were picking it up.
Yeah. You mentioned, like, some of the attitudinal stuff too. So, I mean, it's forgetfulness, but it's also a change in personality, I think, that you're experiencing. What did that look like?
It got pretty ugly. He, being the person that's always right, I don't mind a good argument myself, but it just exploded He was far more
determined.
Yeah.
And hearing some of these things, I'm sure people listening to this podcast would realise, yep, that's me. That's that you see yourself in many of these comments. But there must have been a point where you said, okay, we need to get a clinical assessment here. Something's not right. When did that sort of happen?
Oh, I think I openly said to someone in about 2019, I think there's something wrong with John. And it just became real obvious when COVID hit and he was working from home.
Right.
The silly things, uploads, downloads, blame the computer, blame the people at work. They're forgetting things. The remote control. There's something wrong. Someone's changed this. And, his ability to use a phone, the ability to use a new phone.
Right.
Forget it.
Yeah, right.
Yeah. And he had one of those old little Nokias with the, tiny, and I think it was on 2G, and they gave him an iPhone. Oh my gosh.
Right.
Yeah.
Right. The lockdown period must have been interesting for you then, because that sort of constant interaction with an individual. And I think everyone who went through that experiences a variety of difficulties. But with that ongoing, I suppose, frustration he was feeling with the world, that would have been pretty intense at that time.
Oh, it was. And it was hard because, I'm working from home, he's working from home, and I could hear him struggling, and he'd get to the stage where the employee trying to coach him through, so he had someone helping him with a lot of this. He'd say, go get your wife.
Right. Wow.
So it's like, oh, hang on, I'm actually working my job. You need to, do that. And he'd get upset about that.
Yeah, fair enough too. I think it's, he wouldn't have known what was happening.
No.
Yeah. And at this point, so you said 2019, he was how old at that point?
59.
59.
Oh,
so,
sorry, 58.
58. So it's not an age where we expect typically for this sort of stuff to be coming into play.
No.
Yeah. And you went and you got, clinical sort of assessment. What?
It was a battle.
Yeah, what did that look like?
To get that done. I keep sending him off to the doctor, and his doctor said it's stress, recommended some therapy. He did one session of that and said, oh, it's all crap. I don't need this. Cancelled that.
Yep.
And it was a constant push. We've lived where we are for nearly 30 years.
Right.
And neighbours were, pulling me up and going, what's wrong with John?
Yeah.
Is he having a few drinks or, just things weren't right. They were noticing. And his friends, one of his good friends, said, if you can't get him to the doctors to have something done, I'll take him.
Right.
I thought, oh. And I said, John, Paddy's going to come and get you, take you to the doctors because there's something wrong. And that took absolute ages. That was a battle.
Now, if you're at the other end of that, where you're the clinician, when someone like John comes in, he's very young, what does that discussion look like? How do you do that assessment?
The first thing to say is that you're usually mindful that there has been this sort of long battle even to get to that point, as Annemarie described it. And we know that in Australia, the estimates are that it takes actually over 3 years for people to, from the first onset of symptoms, for them to actually receive a diagnosis of dementia. And so there's often a very long period of time before people present even to a specialist. And, when we've just heard from Annemarie, the challenges that really sort of can happen over that period of time, arriving at a diagnosis of dementia is challenging clinically. It's challenging to seek out specialist assessment and diagnosis because of what we've heard from Annemarie. It's an insidious disease. It's slow. You sort of question yourself. Often the people suffering with the disease don't want to present to a doctor. But when they do present to a specialist, it's very challenging for a number of reasons. One of them is that there are a number of other mental health conditions, medical conditions that can present in a very similar way. So things like severe depression or alcohol, being on medications that affect memory and thinking, cardiovascular disease, can all be what we sometimes call dementia mimics. And so, disentangling the effects of some of those conditions from something that might be presenting as a dementia is challenging. One of the other challenges is that there is no single diagnostic test that we have available to us to make a diagnosis of dementia. And so it really relies on expert clinical assessment with a specialist, often also a specialist nurse, a neuropsychologist, other healthcare workers, to really put together a sort of complex jigsaw puzzle of what's going on, sometimes do some supportive tests to add some further information. So it is challenging to arrive at a diagnosis.
And when you get to the diagnosis, and Annemarie, I want to hear from you on this as well. I mean, what is your expectation there in terms of that interaction with the patient? You're the one delivering it, presumably. How do you, what does that look like?
Yeah, I think the first thing to say is that often people come with a lot of misconceptions about what dementia means and what a diagnosis of dementia means. And so really part of the diagnosis is some education about what we mean when we use the word dementia, and really highlighting that dementia is not a single diagnosis. Dementia is an umbrella term that encapsulates a number of different diseases of the brain that affect memory and thinking, typically over a very long period of time, or over months to years. And we use the term dementia when those memory and thinking problems start to affect people's daily function, like they did in John's case. And so there is that sort of that discussion around what we mean when we talk about dementia and what we don't mean when we talk about dementia, and then talking about the next stage is what is causing the dementia in this case. And there are a number of brain diseases, the most common of which is Alzheimer's disease, but there's also a number of other brain conditions that can cause memory and thinking problems, and disentangling some of the common features of those to try to give us a more precise diagnosis.
So, Annemarie, you hear from Nawaf and he gives you this diagnosis for John. Well, I mean, what did that mean for you? I mean, you've been seeing all this stuff, struggling with this stuff. Friends are making comments about doing the hard doctor work if you don't, trying to help you. But what did the diagnosis mean?
For me, it gave me a reason for why he was acting the way he was. Other people had said, oh, gosh, I've got a friend and he actually had a brain tumour. So prior to that diagnosis, I didn't know what I was dealing with.
Right.
Yeah.
What did it mean for John?
He actually, and even now, if he could tell you, he'd say, there's nothing wrong with me.
Right.
Nothing wrong. But when he actually heard those words, he went home and he was in a funk for about 2 days.
Right.
He just wanted to lie in bed. About day 3, he got up and goes, nah, it's wrong. Nothing wrong with me. As he walks out the front door and forgets to close it, you know.
Right. Has that shifted at all, or has his sort of distance from the reality of it gotten worse?
I don't think it's shifted much. He still thinks there's nothing wrong. So, I mean, July of 23, he went missing for 2 days. And now we need to ensure that he's with someone at all times. He's got trackers on. Hopefully he keeps them on. But he still thinks there's nothing wrong.
Right.
And he still thinks he should be allowed to go wherever he wants and do whatever he wants. But the risk is he's a danger to himself.
Yep.
And, he could ruin someone's life out in the community. I mean, the poor guy that's driving at 2 a.m. and John's wandering around, and hits him.
Tell me about his cognition changes. So memory obviously is something, forgetting the doors. His sense of a need for freedom is intact. What various aspects of his cognition have changed? Like, is his problem-solving ability still there? What sort of things are different?
look, for a guy that worked in the field that he did, if I, dropped a jar of coins and said sort them into various nominations,
Yep.
he can't even do that now.
Right.
He can't write. He struggles to read. Words are just not coming. Sentences aren't full sentences, and he'll always finish off with a yeah.
Right. Interesting.
Positive.
Can it's interesting you say that. Like I wanted to know. Can you tell what he enjoys at this point?
He, loved his sport. Grew up playing, football, golf. Used to swim every day. He doesn't like, doesn't want to play golf. Doesn't want to, go swimming. Doesn't want to. He's become really chill about everything. He'd be happy to possibly sit down on the couch, and I put on therapeutic music for one of the dogs we have because she gets really anxious when there's a storm coming. He loves that. Keeps him amused. Yeah.
And what does a good day look like for you, for John at the moment?
A good day, he's in a good mood. He's happy, but you're doing breakfast for him, you're brushing his teeth for him, you're reminding him to go to the toilet, you're changing his clothes because if he puts them on, it's either really out of season, he'll wear a really thick jacket on a really hot day, pants are on inside out, different coloured shoes, 2 socks on 1 foot. He needs a lot of help. So you're preparing the meals, making sure he drinks, all of that, yeah.
And if you don't mind, what's a bad day look like for John?
If he hasn't slept well, he's agitated, he wants to do something, doesn't know what he wants to do, gets nasty with people, can't verbalise well enough, but, you can tell by the look on his face that it's not a good day. He'll refuse help.
Right.
Yeah. Won't refuse to eat. You put the food in front of him, he'll eat it, but, brushing his teeth and, making sure he's, bathed, clean. Yeah. That's hard on those days.
Do you get a break?
We've got support workers that come and take him 4 days a week now. Some of them struggle to keep him out all day. He's become focused on, or reflections are a thing. Dementia Support Australia came out and tried to help us with that, but, yes, remove the decorative mirrors, but he's found a reflection in the microwave.
Right.
Put a tea towel on that, he'd nearly pull the microwave out. TV screen is black and blank, there's a reflection there. Windows, reflections. You go shopping, reflections, yeah.
And what does that mean for him when he sees his reflection?
If he's smiling,
Right.
he, nods at the guy.
Right.
I don't think he recognises that it's him. If he's tired and that he's got that scowly look on his face, that guy, he's a problem. So he's actually, had a go at the reflection.
Right.
Yeah.
Right. As you say, it's a difficult thing to remove from your environment entirely. It's everywhere. He'd see it in water, he'd see it in windows as you walk down the shops.
Public transport.
Yeah, the whole way. Yeah,
nice clean windows on the train and, yep.
Yeah,
there it is.
It's interesting, isn't it? I think anyone listening to this would think that's something I hadn't thought about. Just the toxicity of a person's own reflection to their entire encounter on a given day and what that means for you in terms of managing behaviour and managing expectations.
Yeah, deflect, turn around, change the subject. Oh, look at this. Yeah.
Yeah, wow. Annemarie, do you feel as though you have a choice here in terms of how you go forward with John? I think a lot of people would be amazed that you've managed this far, but he's a big, strong individual who has a sense of freedom still in him and wants to exert that, and you have little control. As a person, do you feel you have a choice?
I don't think I have a choice. just have to cope with him the best I can for the amount of time I can. But it's going to be hard to let go. But in a way, I've, lost him. I lost him a long time ago. Mm-hmm. So when it starts to feel like you're looking after a stranger, making a choice to have him placed in care becomes a bit easier.
Are you able to grieve while he's still there? That loss?
Some days I do. Some days I don't.
Yep.
Yeah.
Yeah, fair.
It's a long process.
In terms of the timing for you, you must think about this in terms of what the years coming will look like. Do you have a good view of that, a good understanding, or is it unknown?
There's plenty of knowns. You do a lot of reading, do a lot of talking. It feels grim. Mm. Yeah. And I know I'm going to get to the stage where, I can't cope with him at home. Yep. He's a constant absconder. He's a bigger guy than I am. Physically, walks straight, erect, can run, jog. He jumped the driveway gate to get out one time. So he's physically strong. But it's like a 3-year-old in that body. Yeah,
yeah. I think anyone listening to the podcast would be amazed that you are managing the situation that you are right now. You probably are some days too.
Yeah. I'm amazed, but there are days where, my hands will just be shaking. Yeah. I'm just, Yeah.
Well, extraordinary.
Getting tired.
As I think any of us would be. It's an impossible situation that doing an amazing job with your husband. Now, I want to talk to you a lot about the clinical assessment process because obviously there's a bit of a gatekeeping scenario there with GPs. People have to get through that gate before they would see a neurologist. How well is that working? Do you find you're frustrated because people get you too late? Like talk me through that.
I think it's variable, Shane. I think there is a lot of variability across the country. In terms of how efficiently people get to specialist assessment. And it doesn't have to be a neurologist. It can be a neurologist or a geriatrician or a psychiatrist in some cases. And there's variability depending on, I guess, other factors that often affect access to healthcare, socioeconomic factors. People from culturally and linguistically diverse backgrounds often that sort of journey is longer and more complex. I work in a major tertiary centre and, in our clinic I think we're very blessed to have access to sort of a multidisciplinary team, very experienced nurses, very experienced allied health professionals. We geriatricians, neurologists, psychiatrists that work together, but that is not available everywhere. And so I think there still is a lot of variation in terms of people's access to expert assessment. And I think moving forward, there also does need to be, dementia is a condition that's really growing in prevalence as we age as a community, and I think a lot of the future assessment will be done by GPs, at least the initial screening. So there needs to be more of a partnership, I think, and education and sort of empowerment of our GP colleagues to be more confident to assess people when they arrive with these memory and thinking problems.
When these people are coming in your door, there's, as you mentioned earlier, there are many different forms of dementia. How do you separate them? And the other question there is, given there's a lot of lack of treatments in a sense, how valuable is that separation?
Okay, well, I'll, if you don't mind, I'll start with the second question. I think it is incredibly valuable to try to give more precision in our diagnostic workup. And the first reason is that it for most of the patients I see, it matters to the patient and their caregivers to have some precision as to what is going on in the brain. And the second reason is that we are entering an era where for some forms of dementia that there are now disease-modifying therapies on the horizon. And so it is really important for us to try to be as precise as we can in giving a diagnosis. There's also reasons around prognosis and around certain types of treatment that should be avoided in some forms of dementia. For example, dementia with Lewy bodies, which is a common unrecognized form of dementia. Certain forms of antipsychotic medications can really worsen outcomes in those patients. So there are a number of reasons why it's important to be precise. Now, how we do that is more challenging in real-world practice, because what we have available to us is what we call clinical diagnostic criteria, which are based on pattern recognition, essentially, of what are the common ways that these dementias present. For example, in most cases, Alzheimer's disease, the common form of dementia, presents with short-term memory loss as an early feature. We've already heard that in John's case, that wasn't necessarily the case. So there are exceptions to the rules, and so it means that these diagnostic criteria they're very helpful, but they're somewhat imperfect, and that's why we need more precise measures of the changes that are happening in the brain.
Can I ask there, when you say short-term memory loss, I think myself and probably half of our audience is thinking, we all get there. Is it what you're talking about different though? Like, I forget people I met, I forget their names, remember their faces. Is that what we're talking about, or is it far more extensive?
No, it is more pervasive and it's more recurrent, and it's you're right. We all, including myself, will walk into a room and forget, hang on, what did I come in here for? Or we'll lose our keys from time to time. But the type of symptoms that we're talking about here are, become really severe and become pervasive to the point where some people, will be asking the same question over and over again, and despite continued responses, will not be able to take on new information. So there is obviously a spectrum, and part of the challenge in making a dementia diagnosis is to try to disentangle where on that spectrum and when do we start to become seriously concerned about such symptoms.
What about the role of imaging? We have some amazing imaging capabilities, functional MRI machines at the Florey and at the Royal Melbourne Hospital. Of course, you have one of the strongest 7 Tesla MRIs, which has much better resolution to the sort of standard ones, that are the more common. Does that get us anywhere?
So MRI is helpful. MRI gives us a picture of the structure of the brain. It can sometimes rule out other conditions that can appear clinically like dementia. Annemarie mentioned a friend who mentioned a brain tumour. That's something that sometimes you'll see unexpectedly, or other issues with increased pressure in the brain. And in other cases, there can be sort of patterns of loss of brain volume on the MRI that can help push you in a certain direction in terms of a diagnostic workup. For example, Alzheimer's disease usually causes volume loss in the temporal lobes, for example. Now, it's only a piece of the puzzle. This is the part of the conversation with patients, is that the MRI doesn't give us the diagnosis. The MRI is a piece of the puzzle alongside the expert clinical assessment, and sometimes the MRI will give you some increased confidence in the diagnosis, or will point you away from certain diagnoses, but it's not enough on its own to give us a diagnosis.
What about biomarkers? How are we going in that space? Because obviously that's the benchmark for so many different physical conditions that we face as human beings. If you've got a good biomarker, you can test early, and we've seen this with things like cancer and, all sorts of kidney diseases and so forth. Good biomarkers are really helpful. Are there biomarkers we can utilise for dementia?
I think so. So I think that's the future. There are a number of biomarkers really emerging that are very helpful. So in the case of Alzheimer's disease, again, usually we sort of use our examples based on this condition. It's the most common form of dementia. Amyloid PET scanning is very helpful. So amyloid or amyloid beta is the protein that's deposited in the brain very early on.
The plaques.
Plaques,
yep.
In Alzheimer's disease. And so a PET scanning using a tracer that binds to these amyloid plaques in the brain can help us measure the level of amyloid in the brain and see which parts of the brain have been affected. So that's technology that's been around for quite a long time now. It's not readily accessible in clinical practice yet. There's issues around availability of scanning, access of scanning, cost. The other helpful biomarker is measurement of dementia-related proteins in spinal fluid using a lumbar puncture, which often puts people off when you say lumbar puncture. And the reality is many of our patients, particularly older patients, are on things like blood thinners or have other reasons why lumbar punctures are not appropriate. But it is a very reliable and accurate way to measure the levels of proteins that are associated with Alzheimer's disease. So that's what we have at the moment, but really what we are hoping for in the future is a blood test, which will be much more accessible, much more scalable, and hopefully will allow us to make an accurate diagnosis really early on.
Rebecca, you've heard already a lot about the situation that Annemarie describes with John, and also from Nawaf with regards to the clinical experience. You're very much in the future, looking towards what can be done, and these processes of research take a very long time. What's your sort of assessment so far of the pathways that have been taken towards treatment protocols? Have there been some good ones? Have they all gone off in a direction that sadly has not, resulted in an outcome that's viable? Where are we at the moment? And, we're recording this in 2024.
So we are, as Nawaf mentioned, we're in a new era of dementia treatment. So the FDA has recently approved a number of disease-modifying treatments for Alzheimer's disease. These haven't been approved in Australia, but it really now opens the door to new therapies coming through in the future. So I guess the challenges with developing drugs for dementia is not just one disease, as Nawaf mentioned. It's a number of different diseases that all lead to the common symptom of having dementia. So we have each of these individual diseases that are all caused by different toxic molecules in the brain. And so we still really need to identify what these toxic molecules are and how they interact to then cause the death of our brain cells and dementia. So whilst we know a couple of really good targets, and one of those is the amyloid beta protein, which is the target of the current FDA-approved therapies, there's still a lot we don't know, and that's just for Alzheimer's disease. It doesn't apply to other neurological diseases as well. So the other thing we need to think about as well is these diseases are often a cascade. So we have, for example, molecule A that then drives molecule B, that then drives molecule C, which then leads to the death of our brain cells and dementia. So what we need to be certain is that we're targeting the right molecule at the right time in the disease progression. And that's another limitation, I think, of the field, is that we haven't been able to diagnose participants in clinical trials early enough to then target the disease specifically with the correct therapeutic target. So, for example, the amyloid beta protein for Alzheimer's disease, that's the current target. It happens very, very early on in disease. So that's sort of molecule A that drives the toxic cascade. But if you're treating somebody with sort of mild to late onset Alzheimer's disease, the damage is done. So we're not going to get those therapeutic outcomes in clinical trials that we really hope for, and that's sort of where we're at.
Interesting. I remember reading years ago about the amyloid plaques and so forth, and one of the questions I have for you as a result of that is, how do you know which is a damage-causing molecule versus a response from the brain to the disease molecule? Are we able to do that with the amyloids at this point, or is that's still a question that's out there? Yeah,
so this is where it's a bit of controversy in the field, and it's hard because we're also working with an ageing brain where our proteins are behaving differently anyway. So we need to separate what's normal aging from what is actually driving disease pathogenesis. And we're quite certain on a number of molecules, for example, amyloid beta and tau in Alzheimer's disease are driving this. And this is many, many years of research where you use disease models, particularly mouse models. You take out one protein in these mouse models and look at the effect. Take out another protein and look at the effect. And we have shown that, for example, the tau protein, when you knock that out, take it out in a mouse model of Alzheimer's disease, you don't get the neurotoxicity, the neuron cell death that you get when the tau protein's there. So we know that that's probably a very important protein in the disease that we're targeting. And we know that A-beta seems to kickstart that tau pathology in the brain as well. So that's also why that A-beta is quite a common therapeutic target too. Now,
at the Florey, you run the antibody therapeutics group. And when I hear antibody, I hear immune system. We've seen extraordinary outcomes from the study of the immune system and its ability to deal with cancer. How does the immune system play into potential treatments for dementia and Alzheimer's in particular?
Yeah, so antibodies are these really cool molecules that our body produce in response to disease, and they can be lifelong. They circulate in our blood, and when our body comes into contact with an infection, a disease, and we've already got antibodies present, it'll fight that disease, stimulate the immune system and clear that molecule, that toxic molecule from the body before it presents with the disease symptoms. But what we can also do is make antibodies in the lab to target specific proteins. And this is what we've done in the field of dementia research. We've taken we've generated antibodies that can specifically bind to these toxic molecules in dementia. And what we can do is inject those antibodies into the bloodstream and use them as a treatment.
Presumably this overcomes the blood-brain barrier issue with a lot of pharmaceuticals, is that?
No. So unfortunately, yes. So one of the biggest challenges for treating neurological diseases is that our brain is very well protected by what's called the blood-brain barrier. The blood-brain barrier is a network of cells that bind very tightly to each other, and it prevents any molecules in our blood that isn't supposed to get into our brain from actually getting into the brain. So in doing that, though, it actually prevents any drugs that we've administered in the bloodstream from getting into the brain. And unfortunately, antibodies are very large, and only about 0.1% of antibodies can enter the brain. So, yeah.
Right. And to get enough in, does that then become a toxicity problem for the rest of the body?
Not a toxicity problem. It becomes quite expensive,
right?
And you need fortnightly or weekly infusions, for example. So, yeah, we're really trying to overcome those limitations by enhancing delivery of therapeutics into the brain and trying to make it a one-off treatment rather than having to have repeated administrations of drug.
If this is all successful, are we talking about winding things back or halting disease? Like what's and perhaps it's the wrong question to ask because I suspect the real answer is all of the above, but are you targeting one or the other?
We are really hoping to prevent disease eventually. So going back to your question with how we can use the immune system to fight these diseases, we can develop preventative vaccines like we do for other diseases, and that's exactly what we're doing in the lab at the moment as well. So not only can we make these antibodies in the lab, but we can also make vaccines to allow our body to make protective antibodies. So our ideal vision for these diseases is that everybody would have access to a preventative vaccine, say at the age of 45, that would actually prevent the onset of disease later on.
Amazing. How does the funding situation stack up for dementia in comparison to other health issues, diabetes, cancer, etc.?
Yeah, not great. So I think dementia is actually going to surpass heart disease as the leading cause of death of Australians soon. It's expected to surpass cardiovascular disease. At the moment, it's the leading cause of death of Australian women and the second leading cause of death of Australians in total. But we get significantly less funding for dementia research compared to cancer and heart disease. So it is a problem. We're not short of excellent ideas and talented researchers, just funding to really drive this research to translation to actually produce therapeutics for patients. So at the moment, 100% of my research is funded by philanthropy or foundations. So, yeah.
Not the best. Question that we'll be asking every researcher on the Brain Matters podcast. If you suddenly had a massive influx of funding, what would be your very next thing to do? Like, what would you go after?
Yeah, so what we're doing at the moment, and which we can really make quite bigger, is we're using the technology that was developed for the COVID vaccines to make new treatments, the next generation of treatments for dementia-causing diseases. So rather than delivering our therapeutics in the conventional format, which is called a protein, proteins are quite large, as I mentioned, and unable to get into the brain. What we're doing is taking the genetic information of these therapeutics. This is called DNA or RNA. And we're packaging it into these tiny delivery vehicles that can cross the blood-brain barrier and to deliver the genetic information to our brain cells. Our brain cells can then read that information and make the drug itself. So our drug's exactly where it needs to be effective. And the analogy I like to use for this is, for example, you've ordered a king-size bed and it comes fully assembled. You can't get it through the front door, which is like the blood-brain barrier, and you can't get it into your bedroom because it's too big. So rather than having it delivered as a fully assembled king-size bed, you would have a flat pack with instructions. It's cheaper to produce, significantly cheaper. You can get it into the brain and you can get it into our brain cells, and there the brain cells can read this information just like a flat pack and an instruction manual and make the drug itself. So this is where we're investing all our research at the moment. And what's really cool about it is that we can use this strategy to target really any new therapeutic targets that come out from research. We can use this strategy to target those. So it's applicable to multiple diseases as well as therapeutic targets.
So basically a lot more money, fast track that research and get some of those things out.
Yes.
Yep. Fantastic, Rebecca. Nawaf, I want to ask you the same question. If there was suddenly a big briefcase, and I'm talking a very big briefcase of cash, what would that mean for you clinically? What would you change? What would you do?
Yeah, I think it's a complex question. So, when we're talking about therapeutics, as I said before, I think we're in a really exciting era. We're at the start of the era, and the drugs that are coming through the pipeline at the moment are for the first time disease-modifying for Alzheimer's disease. And I look at other fields, for example, the field of cancer, where over the last 50 years, essentially a revolution over that time in terms of sort of precision medicine, how effective the treatments have become. Another area in neuroscience is multiple sclerosis, where 30 years ago, the first, drugs for multiple sclerosis were available, and the initial round of drugs were sort of modest in terms of their efficacy and had some issues but over time, with engagement and with research and with particularly clinical trials, the improvements in that kind of efficacy of treatment has been great to see. And so I think with half of the funding package that you've talked about, I would really try to sort of get us ready for these new treatments. These are infusions, as Beck mentioned, and so it's a completely new model of care for people with dementia to come into an infusion centre to receive a monthly or a fortnightly infusion over a up to 18 months period. And so we need the staffing, we need the sort of infusion centres, we need the models to sort of monitor people with MRI scans to ensure their safety over that period of time. So this is a sort of a new era of care that comes with great sort of promise, but also that we need to sort of be prepared for this kind of work. The second element of the funding is really around that support and care package, and the reality is that with the current drugs that are in the pipeline, we estimate that they are only available for about 10% at most of our patients currently.
Right.
I think that's going to change. That number is going to expand with new drugs. They might become available for more and more people over coming years, but we really can't forget that there are many people who are not eligible for these drugs at this point in time, and they need coordinated long-term care in the community to sort of manage their symptoms and this progressive condition. And I think that's something that often is forgotten in these conversations.
Yeah. Annemarie, I kind of want to finish with you here, because when you hear about these things, they're all very future-focused. They sound great. You must feel you're out of time in a sense, and that this came early. How do you reflect on that?
I wish it had come earlier, but I'm hopeful for all the people that are going to go through this, that this work can be done.
Yeah.
Because you'd hate to see someone go through what we are going through.
Annemarie, thank you for today. It has been an absolute privilege speaking to you, and I know people refer to you as stoic. I know it must feel like you have a choice at times, but I think anyone listening to the program would be incredibly impressed with not just how clearly you've articulated your story, but what you're doing and what's ahead. So thank you.
A pleasure.
Rebecca, thanks so much for talking to us about your research. No pressure. Please hurry up. Hopefully you'll get more funding, and the more we get the word out, the better.
Thank you. Thanks, Shane.
And Nawaf, I don't envy you your daily job. I hope you get a lot of joy out of giving people some clarity in the clinical sort of experiences that you provide, but keep doing it.
Thank you.
You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have particular topics you'd like us to cover, please get in contact. I'm Dr. Shane Huntington. Thank you for listening.